Thank you, David.
How do you mention the title? I guess that would be a good thing to say, reiterate. Healthcare proxies and living wills, clinician involvement in executing and evaluating advanced directives.
Actually, I changed it. Okay. Now let's see if I can see this right. Okay. Scope and limits of advanced directives. I feel a little bit like the old saying about carrying coals to Newcastle, because among other things, David is here. He's done a lot of work in advanced directives. I notice in this series that you've had this discussed before, and I was actually just given a book by David that he and a colleague wrote on advanced directives, planning for uncertainty, which hopefully will hit the bestseller list anytime soon.
Yes. Oh, boy. Number 308,000 or something, I think.
Yes. Anyways, I'm thinking of myself a little bit, and hopefully we can do this, like the old thing with Socrates, who said, you know, I really don't bring anything to these discussions. I'm not, he might have said, if he had foresight, I'm not Plato, I'm not going to give you a whole theory. Whether I'm going to function as a midwife, I think you folks have the answers. I'm going to draw them out of you somehow. Okay, this is certainly an area that a lot of it I think everybody's familiar with in some sense. I think at least my experience is most people, at least in their families or acquaintances, have had situations where people, at least by hindsight, were overtreated. We wished we hadn't done it. You know, the old thing like, I wish we hadn't called 911 for grandma. It was pretty tough, you know. I routinely tell my residents to assume there are stories in a family when we get to this point where we're discussing whether to be aggressive or not. There will absolutely be stories in a family about what happened, and it will color how they respond to you. So the first, second, and third thing to do is try to get those stories out. And if somebody says something that doesn't make sense, ask them why. And you'll probably get, well, Uncle Al went to Buffalo General, and this is what happened to him, and I wish we hadn't done that. Or Auntie M got chemo, and oh my God, I wish we hadn't done that. Whatever, okay? Hindsight being 20/20, and that's a discussion that needs to occur. Interestingly, and we'll try to get a handle on this, there's a website that David and I more or less lurk on that is put out for, let's see, you have to ask permission to be on it, and it's for folks that are it's kind of an elitist thing, I guess, right? If you're involved in bioethics, you can receive the emails and all the rest. And they recently had a discussion about advanced directives and things like substituted judgment. What's a surrogate doing when they decide for somebody else whether to be aggressive or not? And I think the thing that struck me most was here, what is it? It's 2008. 20 years down the line since the idea of advanced directives started to take hold, even in the bioethics community, there's an unsettled view of what things mean, how to do it, what works, what doesn't, which is interesting. And maybe we'll get a handle on that. Maybe nothing is a panacea, and there's no one way to do it. And no matter how good we are at it, there are going to be profoundly difficult cases that are going to stay profoundly difficult no matter what discussion we have. Okay? But anyways, let me kind of get through this and get it in the sense of getting a few things in front of you. I gather we have till 1:30. I'm not sure how everybody's time is, but what I hope would be, I have 12 slides that I kind of want to get through, and we'll probably do that. But I'd like to encourage you to jump in at any point, raise a question, make a comment. We can pause. There are a few questions I have for you anyways, and we can make this more interactive than the usual lecture, okay? Definitely feel encouraged. I think it'll all work out better. That's me playing Socrates. Okay, I want to get your babies out here. Okay. Advanced directives, why bother? Advanced directives, of course, there are a number of forms of them, but basically the idea is that when the issue of whether to be aggressive or not comes up, I may not be available to comment. Therefore, how do I make it so who makes the decision, who sorts all that out? There are a number of ways to do this. The basic formal ones are healthcare proxies, where somebody simply designates somebody else to speak for them, or a living will, which is more informational, as in, if this happens to me, I do or don't want that. If I'm in a persistent vegetative state, I would just want to be kept comfortable, that sort of stuff. And we'll review some of those. The more poetic form of this sort of solution would be a values history, which David and our friend McCullough were the pioneers of this. I refer to it as a more poetic way of proceeding. It's not just a name a clinical situation like PBS and say what you don't want. It asks more broad-ranging questions about what you think of your life, what's important to you, that sort of stuff. And then there's verbal prior statements and discussions. Why bother with this sort of stuff? Perception of over-treatment at the end of life. I assume everybody knows what I mean there. That's Uncle Al on 9 going to Buffalo General or wherever. And I will add to that my own little primal intuition. In my case, and I know in a number of others, when I started in medical school in '79. In a lot of cases, it was an older physician trained before the war that was kind of waiting for us as we walked in the door. And they had kind of a different perspective, different from the NIH-trained and led physicians that came out after the war, where we've got this much larger capacity to keep people alive and do things. And the bias should definitely be that we do that at almost at all costs. I think that my sense was that mentality was there. And these older docs were waiting for folks like me to come trotting in the door who are looking at it from a different perspective. Okay? Does that sound, you know what I mean, David? Some of our older colleagues, they're all chief of staffs now and chairs and stuff like that. And they've got over some of it, but they really kind of dragged their feet for a long time, okay? It was like, let's say, it was like pulling hen's teeth to get a DNR. Of course you couldn't pull a plug because the DA would be over and arrest you, okay? So therefore we had to, if we had somebody that wasn't going to make it, we put them down to 4 puffs. You all know what 4 puffs is? Well, if somebody's on a ventilator and it's really time to stop and they need an exit, these days we just, give them some morphine and the rest and stop the ventilator. Well, you couldn't do that back then, so what you did, you put them down to 4 breaths from the ventilator a minute, and they'd just kind of slowly lapse into unconsciousness, but they'd be, you're grimacing, that's appropriate, sir. This was grimace time, not a good way to go, all right? Legal and ethical problems with next of kin deciding. Now, I'm from New York State. We have enormous legal problems. The lawyers have been hyperactive in New York State about these issues. Unfortunately, we have all sorts of difficulties. I'm reassured by David and his colleagues that the lawyers don't get too much involved here, so your questions are more ethical. As in who decides, what should the decision be, what's the basis of it, that sort of stuff, which can be tough enough. Okay? And finally, why bother? I think anybody that's taken a good look sees that there isn't one right way to go with a lot of the, not just end of life, but when you get into chronic illness or threatening terminal illness, people choose differently given the same set of facts. The same person with a certain type of cancer, say pancreatic CA, so, half of them will choose to go to a local research institute and half of them will be talking about hospice, right? So there's no one right medical answer to that. I think there's a lot of that, where if we gave them a chance, people would say different things. It's not unanimous. Okay, so that's the why bother part. The logic of advanced directives. This is where, if you didn't otherwise know that I have a philosophy PhD, it becomes apparent with the word logic, right? Logic is roughly the following. First, patient autonomy rules generally, but patient is often unavailable for comment when the issue arises. I'm going to go through it a little bit more, but I assume that in the land of the free, home of the brave, in the end, if the patient is competent or has decision-making capacity, you've all bought in the idea that if they say no, it's no. Okay, if they're making what you think is a stupid, foolish, tragic decision or whatever, you can counsel them in that regard, but they have to change their minds. We don't get to drag them kicking and screaming to the OR anymore, and we'd rather have it that way, right? So say we all? Okay, good enough. All right. So patient autonomy rules, but the patient's often unavailable for comment when the issue arises. Now, traditionally and regularly, we would go to the next of kin. But there are, just from experience, problems with this. In New York State, certainly there's legal uncertainty. As I'll point out later, if you don't know, there is a list of ranking surrogates in Kentucky, and the higher ranked gets to make decisions. So that is a place where you have the advantage of us. You have to watch out for me. At one point, I started to comment on at some national meeting about what was going on in New York State. And somebody raised their hand as I started making the comment, and they said, Stephen, could we restrict the discussions here to what's going on in civilized polities? I said, okay, you're right. Aside from that, you know, a lot of times when you're talking to the ranking surrogate, you're talking to the heir. Now there's conflict of interest there, right? You're also talking to dependents. I mean, how families can get this poorly and you can, or not do the job right when the issue arises, the issue of whether to be aggressive or not, is they, you know, may be thinking a little too much, maybe not that consciously really, of, well, you know, they're going to get the house and the insurance thing and this, that, and the other thing, and they won't spend down the estate because Grandpa going to go to the nursing home at around here, $8,000-9,000 a month. Is that about right? You can get rid of a 5 or 6? Really? Wow, cheap. Cheap.
Move here, Stephen.
Huh? Jesus, I guess. I better. I'll be right down. So you could see somebody stopping a little early. There are any number of reasons. We had a 40-year-old come in with bilateral bronchopneumonia, and somebody we were going to be able to treat. He wasn't cachectic or anything. And all of a sudden, the sister showed up and started talking about death with dignity. Okay, now we have kind of algorithms for that and ways to ignore people who are saying stupid and nasty things, and we managed to treat his pneumonia and took care of that, so we were fine. But all sorts of scenarios like that. On the other hand, you can have dependents. I mean, one way it works out is we have steel workers who are in their 70s and 80s in Buffalo, New York. And I'm sure you've got people like this here who have pensions that are very nice and supporting extended families. And those pensions evaporate when the pensioner dies, right then. That's it. And that can really skew some decisions. Interestingly, had a little old lady one time that I was asked to see. Her husband had had multiple strokes and was felt to be neither sending nor receiving. And my residents had, I think appropriately, raised issues of DNR and aggressiveness of treatment. And she wasn't buying any of it, and they asked me to talk to her. And after I got to know her a little bit, she was fairly candid with me. She says, you need to understand, my husband and I, we have a daughter who's disabled. We've spent all our money and mortgaged our house to the third mortgage to take care of the care that she wouldn't otherwise get and does need. And if he were to die, we'd basically not be able to get her that care, and we'd roughly be out on the street. Okay? So she said, that's why I'm being a little hesitant here. And what she then said, she said was, if you can prove to me that he is suffering, I will consider backing off. But if he's not suffering, I want you to keep him alive for as long as you can. Okay? Now, my initial reaction to that was, oh, it's another nasty family member, that's. And then after I got over that, I found myself thinking, well, what are surrogates supposed to do? Well, what we want them to do is to give us a decision that they best think the patient themselves would give us. We call it substituted judgment in the field. And I found myself thinking, goodness, there's a real good chance that she's doing exactly that. That if we asked her husband, that's what he'd say too. Okay? So, anyway, he was not feeling any pain, and we kept him going as long as whatever. I'm a little bit lackadaisical about all that stuff. When the money thing comes up, I have a tendency to look at the residents and say, who authorized you or told you you should be worrying about the gross national product here? Okay, why don't we just stick to what's in the patient's and their family's best interest? That's tough enough. We can think about that, but that's probably not the most responsible moral position to take in the area, but it comforts me. Okay? Anyway. Some next of kin have an inability to do it. They can't see themselves stopping, and the rest, I think that's partially a question of how we present it to them. Present you another case. I had a former medical director, so the family was somewhat medically literate. And there was a wife and 2 daughters, and they had been, this man is on a vent, metastatic cancer, wasted, very much end of life. And they were refusing DNR and all the rest and backing off, and didn't even want to medicate him adequately because they were worried that that might depress his respirations, that sort of thing. So this guy was not only dying, he was dying badly. And I just kind of stumbled into this, and I kind of asked them, and they said, no, we couldn't do this for Dad. And it quickly emerged this was kind of a Gloria Steinem sort of situation where Dad had made the decisions for everybody for all that time, and they couldn't really think of themselves as making them. And at one point I just stumbled into it. I said, well, because what I'd learned is the most important thing is to go through the facts of the case for the surrogates. Talk about, well, what's the patient's history? What has happened to them? What might we be able to do? What can't we do? Okay? Does that make sense to you? Does that comport with what you've heard? That sort of stuff. My bias is, and this is a funny one for a philosopher, once all the facts are on the table, once all that's down and agreed to, a lot of times the punchline is fairly straightforward and everybody in the room is going to tend to agree with it. A lot of dilemmas, in my experience, dissolve for all the, and you just have to have the appropriate players to agree they're dissolved. Okay, but anyway, at some point I just said to him, I said, well, okay, I understand your feelings, why you want to continue, but what do you think your husband would say if he had heard what we just said to you? All 3 of them immediately say, oh, he wouldn't want any of this. He would be mad as hell at us. Whatever, okay? And I said, well, can't we just honor that if you're sure this is what he wants? That's all we wanted out of you. And I remember them saying, is that all? And I said, hey, we're looking for somebody to make a decision, make the best guess as to what the patient would want. I really don't care what you would want if you were in his shoes because you're not there, okay? What his best interests are, I think I'd more tend to rely on the docs and all the rest because they've seen it and you haven't. But what I can rely on you on, hopefully, and usually I find you can with families, is what would the patient want if he was presented with these facts? And they said, oh, he wouldn't want it, et cetera, et cetera. And I just said, I believe you. You've known him for how many? 45 years. You know, well, and at some point they says, is that all? I says, well, that's all if you're comfortable with it. I certainly am. I believe you. Okay. Disagreements between surrogates is the same way. We'll look at the surrogate list shortly, but at one level, the surrogates, if there's no spouse, you go to the adult children. Okay, I walked into a situation where it wasn't clear at all what the best thing. 80-year-old guy had played a full game of ice hockey the night before and then had a massive heart attack. Big league heart attack. It looked like he'd had so much damage that we weren't going to be able to get him on the vent, that he was viable only on a ventilator. But it wasn't clear, and you only prove that with a long clinical course. A very precarious one that a patient very, very well might, you get EAFR and then they fall off, that sort of thing, long term. But you couldn't say it wouldn't work. Anyways, 9 kids, everybody including a international investment banker who flew in from London, a Hare Krishna devotee of 30 some odd years who flew in from India, a CCU nurse from California, and miscellaneous other folks. Now, the chance that all those people are going to agree is just about zip, right? Actually, just to give you the punchline, after a long discussion, it turned out I had 8 out of 9, and I decided, perhaps unethically, that it was time to go get a coffee and let them work this out, which means basically the 8 were going to browbeat number 9 into going along, all right? Which they did, appropriately. I think they were right in the end. And then bad folks. Some folks, you know, I mean, we got a $50 Social Security check each month, and that's worth something to us. The pain and suffering of Uncle Al doesn't matter to us because we're not nice people and we don't care about that. $50 will do it. 25 would have, right? We see them every now and then. Therefore, we might want to do something else. The traditional, let's go talk to the family, we should be fairly uncomfortable with that. Okay, that's the punchline. So what do we do? Well, having a healthcare proxy seems prudent, and we're going to discuss that some. The real question I want, and I think that's a no-brainer. I think everybody ought to have one, and we'll kind of go through some of the reasons for that. Where I'm going to kind of settle in is, if you have a healthcare proxy, is a living will needed? And I'm going to tend to take the position I don't think so, and if you've got one, rip it up. Talk to people, but don't put it on paper. By the way, I don't know what your experience is around here, but in New York State, if you go to a financial planner or you go to your lawyer to do a will and stuff like that, I think it's about got to the point where it would be malpractice for them not to strongly encourage you to do both. Do a healthcare proxy and do a living will. And we'll go through what a typical living will says and what you're all going to be asked to do. By the way, I didn't do my poll yet. How many of you actually have healthcare proxies? Okay, living wills? Okay, all right, we got some things to tear up here, I say. Okay, anybody done a values history? Yes, okay. David, you haven't metastasized in that area yet. Then the further issue would be if living wills are not needed, what is the place and nature of verbal prior statements and discussions? How do you do that? Are there ways to make that better so it's more helpful? Okay, so when the issue comes up of whether to be aggressive or not, the family's got a little more to go on than 3 years ago at Thanksgiving dinner, Grandpa said, if I become a burden, don't do anything extraordinary. I mean, in the ICU, that doesn't help us much, right? Kind of going, okay, poetry, right? Bad poetry, not good poetry like the values history. How are we doing? Any questions, comments? Okay. This is a typical healthcare surrogate designation. I took it out of the Kentucky Advanced Directive. It's a state form that David sent me. And it's just simply you designate somebody to speak for you, throw on an alternate in case that person can't do it. These sort of documents sometimes are attached to living wills, which this one is, the Kentucky one is. Sometimes they're not. You can do them separately in New York State. They have both. All of them also offer a space somewhere where you can put in comments. This is where you can say things like, don't ever put me on a ventilator and stuff like that, which we'll also talk about. But, yes?
I have an objection to the Kentucky statement. And that is that both of these designations assume that the patient does not talk to the proposed proxy. If they will not serve, then I name. And if that one refuses or is not able to, then you would think that a designation of a healthcare surrogate or a proxy would require, just by the nature of the thing, to talk with them and accept their refusal and or acceptance prior to putting the name down.
Okay. I've been told, by the way, I should repeat the question or comment for the sake of
Our web stream guests.
the web stream guests. Okay. Let me summarize, and you tell me if I've got this. Basically, the concern is it's all very well and good to designate a proxy, but do they know they're a proxy? Have you had a discussion with them? Is there anything set up to make that discussion happen? And I will second the concern that, I mean, we've called proxies and told them, by the way, your Uncle Al is not competent, we need decisions, you are the proxy, and they go, what, who, when? They have no idea.
And this statement not only allows for that, but assumes it. And I think that's a very bad way of putting a statement about designation of healthcare authority.
Yeah, you know, there's various ways to deal with that. I mean, as an ethics consultant in a VA where we have to worry about policy and procedure, for what it's worth, I'm less concerned about that. What I want to get into is, if we get a document like that, how do we make sure that the staff that receive the document get it in the chart where it's available, okay, and that people make a little call to make sure that proxy is out there, still alive among other things, because sometimes they're not, able to serve. I mean, sometimes we get a demented patient in and the spouse is demented too, right? And willing. There's a number of people that say, oh, I wouldn't be comfortable doing that. I won't do it. Okay? And all of that, see, if you do that when the patient is still available for comment, you can correct that stuff. But this, let's put it this way. As I go through here, one thing you can take away is, I think advanced directives are an interesting idea that probably solve more problems than they create, but I'm not sure how big an increment that is. There's certainly all sorts of ways that they can screw it up and make it worse. That's half of what I'm worried about here. Okay, did I summarize your concern adequately? Okay, so that's the proxy. That's a simple option. Wait a minute. Hello. There. This is the Kentucky. Is it Kentucky? Did I say that right? Kentucky? Yes? That's from, let's say, Last of the Mohegans, the Cooperstown books, right? The hunting ground. Anyway, I've never been to Kentucky before. I like it. You've got an outstanding town. Your colleague here, Dr. Dukas, has been profoundly hospitable, showing me the architecture. Anyways, I'm sorry. Living will directive. This is pretty standard in what it's concerned about. This is the sort of thing you'll get from your financial planner or your attorney or whatever, and it usually mentions a couple of things. And I've got it in blue. Basically, you're going to run into, if I no longer have decisional capacity and have a terminal condition or become permanently unconscious, then I can indicate I don't want certain things. Okay, this is your state directive. This is what the state offers you. Is this from like your Department of Health, something like that?
Attorney General's office.
Okay, all right. So this is the option. This is about what you'd see. Again, there would be a comment section for you to say any number of things. Some of them coherent, some of them not. Yes, please.
This might be a little, I don't know if you want to go this way or not, but I think you also left off one of the things that tends to be on these kinds of documents. There's usually a little disclaimer that if I'm a female who is pregnant, none of that applies.
That's right.
Which I always think is a very important thing to not leave out.
Yes.
It's a very interesting facet of this whole advanced directive.
Interestingly, we've had that whole debate, and I imagine a number of states have, about a concern of how to deal with those persons. And good legislation that would take care of a lot of the problems we have at New York State has floundered on that precise issue. Okay. Not that it wouldn't flounder anywhere, anyhow, because it's New York State, but that's a whole nother, not a civilized polity, like I said. Okay. Another option, just to look at it. Typical values history questions. Now, let's see, how do we do this nice and simply? This is not quite Dr. Dukas's thing from 1991, but it does contain, it's kind of the spirit of it. These sorts of questions, some of them, like I said, is poetic. You can ask people, what would you like to say to someone reading this document about your overall attitude to life? What goals do you have for the future, et cetera, et cetera. Now, how these are going to assist us in the bedside when we're deciding whether we're going to, like, go for that the hockey player with the massive infarct, I'm not quite sure, and at some point we'll give Dr. Dukas a chance to tell us. This is the poetic part, Okay? Is this stuff any better than the, if I become a burden, don't do anything extraordinary? Okay, that's part of the question, I think. This does get down to other things that are more specific. There's a chance to say what you think about your doctors, other care providers. What general comments would you like to make about illness, dying, and death? And then some more specifics that almost incorporate what we just saw in the living will. Okay? So I think, I don't have it opened up here, but I think what I had was at the top I'd written in that I was supposed to mention the word trolling. You all know what trolling is from fishing? This looks like a form of trolling. You're trying to get whatever the patient might say. I will throw in another 2 cents worth of, I'm not sure, and I have to watch this. I mean, I've got a philosophy PhD, and I've had the time to think about what I think. Okay? Now, this may be my version of Obama's thing with the bitter people that everybody's so up in the air about, but I really wonder if most people spending anywhere near that amount of time thinking about these sort of issues, if they've had a chance, and what I worry about is we ask them these questions as if we're being Socrates. We're going to elicit what's there. And I'm not sure it's there for a lot of folks. You know, so I wonder if we're producing something. Anyway, but we'll talk a little bit more about that. So the trolling, you may be trolling for fish and you catch a crab or something, right? And what do you do with, what's the crab tell you? I don't know. Anyway, but again, we have the horse's mouth here, so to keep us honest, David. I'm sorry?
Read the values that are in the values history in the appendix.
I saw that where it's changed, where there's some of these questions, but you've also got living will questions.
Yeah, this is what somebody else had on their website, in which they've incorporated some of our stuff into it. Those are not the things that are in the values history.
Yes, see, we have a colleague who may have plagiarized or done something.
Well, I think they're citing it, but you know.
I assumed this was it when I actually went online, because the first citation is to David and McCullough.
If you pop it open to page 187 or whatever the heck it is, you'll see in the back the values history, and there are 14 different value statements, and they were done based on the work originally done with the Research Retirement Foundation, and then we did empirical studies to show how they correlated with advanced directives.
Okay.
It actually has some relevance in terms of where these things are going to and where they came from.
Okay. Hopefully we will have time to get into that part. One way to put where I'm tending to go, like I said, is I think on the one hand everybody should have a proxy. We should find ways to make sure there's conversation before. I intend to try to speak to that. And the real issue to my mind is if we should be signing any sort of document that makes specific statements about what we want or don't want or anything else. And I have increasingly had my doubts, all right? And I think at some part, in a way that's not quite clear to me yet, David and I part company, which should be a fruitful discussion for everybody. Okay, and I presume myself to be still educable, but we'll see. All right. Let's back up. Patient autonomy rules. Whenever I have the talk, I just go through the land of the free, home of the brave. That's the way everybody wants it. We're cool with that. Okay, not a problem. Next to Quinn ranking, that is the ranking in the state of Kentucky. Anyone with a shred of your DNA that's a David Dukas. That is not something out of the state thing, but it sounds like that's it. It's interesting. One thing isn't there that I think should be that we have in New York State, which is
bloodstream, however, after that.
Okay. Okay. That's important. Yes.
Before the spouse, there's the legally appointed guardian.
Yes, as a matter of fact, if I had them all here, actually doesn't always, for what it's worth. In New York State, the designated proxy designated by the patient ranks above any legal guardian, even if they're said to have that authority. Whereas in Kentucky, it's the other way around. If the judge appoints them and they have that capacity, they are the ranking person, even if there's a healthcare surrogate document generated.
There's a court ruling that says that if the guardian knows of the advance directive of the patient, then there's a file of that.
Okay. The comment was if the guardian knows of a document like this, they should go along with that. Okay. Which is what I saw, particularly in what David sent me, which is over and over. And that's what's important about naming a proxy. If you said things, they're expected to honor them. Okay, so one of the issues would be the patient might say something that's unthought through, or whatever, in ways that I'll talk about. What's the proxy circumstance there? Do they rule? Basically, I'm trying to set it up so the proxy should always rule. Okay, just to bite that particular bullet. Now, if you look at that, some of the things I mentioned before, dependents who may go the wrong way, heirs that may go a different way. What you can see here is why we worry about disagreements among surrogates of the same ranking when you've got the 9 kids, right? Anyone with a shred of your DNA, when I read the stuff that David sent me about the other folks, any shred of DNA, it sounded like, you know, cousins, uncles, aunts, this, that, and the other thing, whether they ever knew the patient or not, are all ranked the same. I think I remember something in there of you can go with the majority if you're the doc. Isn't there a majority rules thing? You can?
With siblings, it's the majority of the adult children.
Okay.
That's what it says in the statute.
Okay, and that can be helpful.
Some states are even worse. Like in New Mexico, they actually require a consensus of the obtainable relatives.
Okay, in New Mexico, they require a consensus of the obtainable relatives, which becomes an interesting issue for your social workers, because what's a good faith attempt to find who's out there, right?
One ring, no rings.
Yeah, right. So anyways, the problems come up. So let's all pick a proxy. Let's just go through that. Usually I find people can do this pretty readily. You ask, you know, Mrs. Jones, she'll say, oh, my husband, why do you ask, whatever, okay? You can pick anybody. I gather in Kentucky you can't pick your doc, which is different than New York. All that New York says is you can pick one of your physician, your nurse, or whoever. It's a recognition of how many people really don't have anybody in this society. I don't know if you've noticed that, but those that folks that work in hospitals, I think it becomes pretty damn apparent. Either they don't have anybody, or I don't know, it seems to be almost a part of the disease of ETOH abuse, of being estranged and all the rest of that. So you can name your physician, but if they're a clinical person, they cannot function as your clinician of whatever description and your proxy at the same time. They can only wear one hat. But I gather in Kentucky you can't do it?
I don't think it's a
You
can't.
can't be named?
I don't think it's a can't. I think it's
Okay.
It's discouraged. And I would say I would argue that it's an inherent conflict of interest.
Discouraged.
Such
What-
persons cannot serve as witness to you.
That's true. They cannot be the
Which makes
And
sense.
by implication, they could not serve as proxy.
Okay. The comment was such persons cannot serve as witnesses, which makes sense. And certainly anybody that is named in the document for one of these functions cannot be a witness. I think that would be universal.
Right.
Okay. You can't witness the document that makes you a proxy. Okay. Is everybody clear, first of all, as to who, if you became incapable of decision making right now, who we would have to go talk to? Is everybody clear? Okay. Is there anybody now, this is statutory, so that's who we go to. Is there anybody that has, sir?
You find all sorts of complications in here. Like, for instance, I have stepchildren and I have a daughter. So then who are the adult children?
Unless there's a case that has dealt with that, I mean, that would be a real issue. Okay. One of the things I'm going to get into, I've got a whole slide that goes into indications for healthcare proxy, where a staff might say, oh, it's this situation, we really need to encourage the patient to designate someone. For example, if I'd known the hockey player beforehand and I knew there were 9 kids of various backgrounds, I would have said, we really need a tiebreaker. Who do you think could make the best guess? Okay. In line with family medicine philosophy, we might still, and I hope we would, encourage the whole family to be there and make it a family decision. It removes some of the burden on the one person, but I've also many times said you have to remember Sister Sue, because we have a proxy, is going to be the tiebreaker here. If you guys can't agree, we're going to have to listen to her.
The real problem is we have patients who are incapacitated. They have no family, and we may have a landlady who actually knows the patient well and may say, here's the types of things I know about Bob, who's now incapacitated. But we have no family member to represent his interests. And
okay.
ethically, we can argue, yes, this person knows somewhat of the values and preferences, but at least looking at the KRS statute, the Kentucky Revised Statute, it doesn't give us direction here.
Okay. Well, actually, let me capture that, because I think that's one thing that's missing that you all ought to have, and I don't think I mentioned this. In New York State, we have another category right after siblings, which is close friend. Did I mention that?
You just did.
Just a little bit. Yeah, and we get in with landladies and the niece that has a good relationship with the patient, that is their care provider in the community,
Or neighbor.
their drinking buddy, their secret girlfriend, whatever, you name it. Right? Whoever. The landlady sounds a little bit weird. For what it's worth, we determine whether or not it was just I get a check from him every month, or a real relationship, and sometimes we find it's a real relationship. If you think about this, what are we looking for with a surrogate? And I'll submit the following. In any case, there's never going to be a lack of medical professionals who are willing to come to the bedside and say what proper evidence-based medicine says should be done here, okay? Occasionally you'll find a doc to say, well, it's 6 of one, half dozen the other, and the only way we sort this out is with the patient or somebody that knows them, okay? But there's not going to be no lack of that. What is lacking and we're looking for is somebody that might know the patient and might be able to answer that question. If the patient had heard what you just heard, what do you think they'd say? Okay, and sometimes it's going to be based on discussions they've had, and sometimes it may be more intuitive, just this is the sort of person he was. And it's my best guess. I mean, I sat there in front of people and just said, the best you can do here is make your best guess as to what Dad would have said. Just make your best guess. You've known him for 20, 30 years, et cetera, et cetera. You're better situated than anybody else. You seem like nice folks. We'll take your word for it. Sir. Really?
What would you do in New York if you had parents with no adult children and you had a lesbian or gay lover?
Actually, we're going to get to that. That's one of my classic examples of an indication that you need to get a proxy real quick. Okay? Yes?
How do you handle somebody?
I'm sorry. The question was, what do we do if we've got parents of a, say, HIV patient, and we have a lover there or whatever? Okay, actually, I'll deal with that right now. What's likely to happen is you call the parents in, and still, even in 2008, there's a real good chance that you're going to have somebody that do not know the patient was gay. That's less, but that's still there. Much more likely they don't know that they have active AIDS. And third, the last thing they're going to allow, which is what you really want, is to ask the lover in and talk to them about what the patient has said, what they might want. Okay, so that's an absolute indication. Our local aid services gets just short of requiring people to fill out proxies because it's caused so many problems and so much discomfort for staff. Okay, because the parents aren't really, a lot of times, aren't able to deal with it. They can't get to the informational basics, where a lot of times the lover will be standing there saying, well, we talked about all this, happened to many of our friends, been there, seen it. He was clear. Now, the interesting thing, if you're in a state where prior verbal statements have legal effect, you can counter the family, okay? Because in the end, as it says in Kentucky, if there are clear, known prior statements by the patient, those rule even over surrogates, okay? I mean, the hierarchy is competent patient says what they want. Next is incompetent patient, while competent, said clearly what they want. Then you get to surrogates. Okay, I think most states have that. You've done more research on this. That's pretty much par for the course, right? How well it's honored, on the other hand, that's different. We've had cases where the patient had been real clear about what they wanted and didn't want. Family didn't buy it. And it's gone to court. More often than not, the judges have been unable to go along with the family, which is another reason to formalize some of this. Okay? So let's pick a proxy. Everybody picked a proxy?
You got one more question.
I'm sorry.
I have a question of when one of those people claims that they have religious beliefs that supersede anything that that person would have said to themselves.
How about
we have to do everything, and I could not vote to do less than everything.
Okay.
So I know that that person would have voted to do less than everything.
Okay, so the question is basically, what if the surrogates indicate they have religious beliefs that whatever the patient might have said or felt, this is the way they have to go? A basic example of that would be Jehovah's Witnesses, right? They cannot consent to blood.
That's an extreme, because there are an awful lot of people who simply said, you have to do everything. Life is in God's hands, not your hands.
Yeah, for what it's interesting, like we have a sizable Catholic population in Buffalo, and it's interesting that a lot of them and a lot of their local priests have a certain view of what the church has said, and one of the things we fairly regularly resort to is get one of the Jesuits or whoever from the university over to make things a little clearer that, no, as a matter of fact, the church allows for the recognition of extraordinary treatment and the rest, that sort of stuff. So we'll end up doing those sort of things too. The Jehovah's Witness thing is interesting because we've had them where they've come in and there's no evidence whatsoever that the patient had ever even looked at being a witness. But they're witnesses and they're refusing transfusions on a patient that will otherwise die, and it's emergent. I'll tell you routinely, I'll just support the idea of transfusing them, period. You know, I mean, if they can prove that they've been studying and the rest.
The witness comes in, and they have a witness card in their wallet.
That's different.
And that they put the appropriate thought into it, regardless of whether they have another advanced directive written or not. But loved one comes in, girlfriend, wife, whatever, a person with a shred of DNA, and they say, save it, just do it. This was actually a case which was believe it or not, on our ethics pager, I had a 911 page where the family was going to overrule a valid Jehovah's Witness patient request by way of a card found in a wallet after a motor vehicle accident.
Wow. Okay.
And I asked the person who was doing the consult, who stat paged me in the middle of I-71, like, what are you going to do? I said, well, what are they doing? Well, the surgeon's getting ready to hang the blood and do the surgery. And this was an easy one to kind of walk through. I said, if this patient refused it, that means they refuse it. That doesn't mean somebody else gets to go ahead and flip it now that the patient is incapacitated. It's very straightforward in terms of the committing of a battery if the person has basically made a very concrete, ironclad refusal that never had been overturned by any subsequent written or oral statements.
And the card constitutes that firm statement, to your mind. Yeah, I would agree. If I ran into that, that's the way I do it, and I think most consultants would tend to, or at least those that have some guts.
The other thing, too, is as an ethics consultant, we can't say you can't do it. We can say this is the ethically correct thing to do, which is to not do it. We can also say that if you do this, A, you can be committing a legal battery. B, you can actually be running afoul of the standards of care for clinicians at the University of Louisville Hospital.
There are a number of ways to let staff know.
Right. And that was what I told this doctor who was doing the consult to tell the other doctor, to make sure that it was really very clear as to what they were talking about, what the bargain with the devil they were about to get into if they hung the blood. Which they didn't.
Just out of curiosity, have you ever looked at a colleague and said just simply, not in my hospital, you're not? Never done that? I'm probably getting too old and long in the tooth. I've done that. Not my hospital, you're not. Okay, has everybody picked a proxy? Anybody pick somebody other than who we'd go to for the sake of the law? Anybody? You're happy with what the law says you should go to, okay? For what it's worth, if you think about it, there is an empowerment sort of thing and a permission sort of thing to proxies that even if you're comfortable with this, with who the lawyers say we would go to. You should still do it because it says it's okay. I want you to do it. Please do it. Okay, take some, for what it's worth psychologically, it takes some of the burden. Think of what you're asking. Okay? All right. Let me, I want to try to debrief you a little bit about why, let's see, where's my little thing? There it is. What sort of reasons, let's see, which order do I, wait a minute. Tell me some of the reasons that, we're going a little long, so I can only do so much of this. Can you say some of the reasons you picked who you picked? Please.
Most of the experience that you already cited were, and he didn't write down my experience, but I have 12 brothers and sisters, and my father was definite of what he wanted in a living will. And my brother was a court guardian and went against that living will, and the court guardian, they backed it up. But anyway, so in my picking my proxy, I picked somebody who would go up against God to do exactly what I wanted to do. So that was from experience and having gone through that.
Okay. How do you spell chutzpah? Anybody know?
Stephen, restate or summarize.
Oh, I'm sorry. The comment was that the lady, one of the ladies in the audience had the experience where Dad had made his wishes clear. One of her brother was a guardian and went absolutely against what Dad wanted, that sort of thing. For what it's worth, that. So I gather if you don't have, say you didn't have adult kids and parents, you'd want to be naming somebody, right? You don't want us talking to your brother, right? Okay, so if things change or something like that. Okay.
Can I entertain one thing?
Yes, please,
like that,
please.
Which is in the values history.
Okay.
Which is a concept called the proxy negation. And that is it's an articulated statement that says that this person under no circumstances is to make decisions on my behalf if I become incapacitated. And it's basically a flipped or an inverted healthcare surrogate. It says, no, you will not be my healthcare surrogate under any circumstance.
Okay, proxy negation for those that you don't want giving input. Interestingly, in my experience, when you look for that, you find it's fairly common. They'll tell you, don't talk to so-and-so, so-and-so shouldn't be part of it, et cetera, et cetera. My classic example of a ranking surrogate who should not be the decision maker is when we had this guy up from Pennsylvania at the VA and had end-stage liver disease from way too many Johnny Walker Red shots. And I ended up being dragooned into calling his wife down in Pennsylvania to tell her what's going on and all the rest. Unbeknownst to me, he had taken a hike about 15 years before. They didn't get divorced, but he hadn't seen her, okay? Period. So anyways, I call her up and go through my little, Mrs. Jones, we have your husband Bob up here at the Buffalo VA, blah, blah, blah. And she just jumped in with, oh, that sumbitch is still alive? And I'm thinking, okay, all right. Switch to plan B here. Anyways, and I pretty quickly told her what was going on, but said, you know, and she let me know she hadn't seen him in 15 years, didn't want to, and all the rest. Kids are actually in the same place, too, because we moved on to that. But I quickly suggested, well, it really wouldn't be fair to you or him to ask you to be decision maker, although you're entitled to do it. And she says, no, I don't want any part of it. Which is another little tactic here for what it's worth. We have surrogates who aren't comfortable, some of who will tell you what their conflicts of interest are and don't believe they should be making the decision, okay? Or they've been estranged or whatever. They can waive. They can step aside, and I think in a fair amount of circumstances it's appropriate for the clinician to suggest that. Okay? All right, so chutzpah would be one of them. Any other sort of considerations? What made you pick the surrogates you did? Is it basically you think they'd probably decide the way you would? Okay, anything else that we should mention? I've got a list here I'm going to go through, but I was wondering what you might say. Anything else you'd add?
I actually just kind of realized mine didn't follow that. You asked if anybody's disagreed, and it's mostly because I am very newly married, and I think my mother still knows more about my values than my husband does yet.
So therefore, you need a proxy.
Yeah, it just
Okay.
occurred to me that mine didn't follow that order. And it's not that I think my husband would make a bad decision. It's just as far as who would actually know the answers to the kind of questions you were asking. He and I haven't had that much time
Okay.
talking all that out in as much detail.
Okay.
My mother is caring for my aging grandmother, and she and I have had a great deal of discussion.
Okay.
So it's not just that she would
Okay.
make the same decision that I would make, but that we've had more discussion about it.
Okay.
It's an opportunity kind of thing.
For what it's worth, one way to deal with that would be to name them both on the same level and that they have to agree. That's one way to do it. Usually I tend to, and most people tend to push for one person. But it's more our needs coming in there than the patient's, arguably. And I've had some families, I remember one lady just said, no, I'm going to name all four of them. I understand why legally it's a good idea, but I'm going to name all four of them, and they can deal with this as a family like they're going to have to deal with everything else as a family. I expect that. Okay, and they'll manage. Some fur may fly, she said, but so what? Fur flies. All right, okay. Let me just go through real quick because I want to get to the living will part of it, but for what it's worth, I pulled this off a website just for your considerations, various things that a proxy should, in some sense, be able to do. Have to be 18 years or older, willing to speak on your behalf, willing to act on your wishes, be able to separate his or her feelings from yours, live close by or willing to come. I'm not so sure what a big deal of that is. I'm less... Being at the bedside and all the rest, I think, is all very nice, well and good, but heretically, I'm not sure how crucial it is. And if we have a proxy in California that's just better at the rest of it, I'm not sure that's crucial. Okay? Know you well, okay? Understand what is important to you. Be willing to talk with you now about sensitive wishes. Willing to listen to your wishes. Able to work with those providing your care to carry out your wishes, available in the future, handle conflicts, handle responsibility, and the chutzpah thing. Okay, my proxy is my wife. She's a very hard-bitten nurse, and any doctor that tries to browbeat her is going to lose an extremity, and I'm not worried about it at all. It's not a problem. The only thing I worry about is one time I said to her, I says, you know, I don't care if the docs say I'm incompetent or not. I want you to go along with whatever I'm saying. You laugh. Well, what? And what did she say to that? She says, well, Stephen, it depends on what you're saying, doesn't it? I thought, okay. Every now and then we take each other's pulse, and I've been told consistently, up to now, that I'm still considered to be worth more above the ground than in it. So I feel okay. Okay. She doesn't know about my secret girlfriend, so I think I'm fine. You should laugh at that. I was kidding. I would not dare.
This is Web Street, that's right.
Yes, okay. Now, indications for naming a health care proxy, go through them quick. Patient may not want the next of kin who is ranked highest, like, you know, they don't like them or whatever, or there's certainly times where they know they have different views. One of my colleagues who has...
It's about to be divorced.
Yes, which David just ran into, all of the above. Need a tiebreaker, that takes care of our 9 kids of the hockey player, or prefers someone not be on the list. Here comes David's thing about proxy negation. The gay HIV patient that we've already discussed. Care provider not ranked, particularly with the veterans population. I find a number of times you got nieces and nephews, particularly nieces. I'm sure Gloria Steinem again will have a comment about that, but who there may be a lousy relationship with their sibs, but they have good relationships with the children of their siblings. They are the care provider in the community. Okay, and I always say to folks, when you see that, that's the one that you should in some sense say to the patient, would you like to name them as your decision maker, because otherwise we're going to be talking to your sister who you're telling me you hate their guts and blah, 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 blah. So, okay.
What about the gay patient that doesn't have HIV?
Yeah.
Why is that a requirement?
I wouldn't, it is not. It is not a requirement. Absolutely. Did you think
Gay patient.
the question would,
Or any patient
okay.
would have a gay...
The question was, what about the gay patient that doesn't have HIV? And the answer certainly is, I would say, a bottom line. You want the person that is closest to and best knows the patient. So anytime that we see that being the case, we should suggest, by the way, you can formalize that. Okay? One way I often put it is, living in New York State, I'm not too keen on lawyers generally. Okay? I'm a little bit of a Henry V person in that regard, if you know what I mean. Are you familiar with the Henry V thing? What's that?
Used to be on my brother's book. First will kill all the lawyers.
Yeah. When Henry V, who was his buddies, was Falstaff and the rest, he was kind of an unruly prince and all the rest of that, and then he finds out that his father's died, so now he's the king, and I think Falstaff asked him, well, what are you going to do first now that you're king? And he thought about it a second. He says, first we will kill all the lawyers, okay? But this proxy thing, I think, is one of their good ideas. I think they're capable of it, okay? And I'll leave it at that. Rank surrogate is problematic for whatever reason. That's another indication. Credibility with healthcare professionals. I'll simply report that in some of these very trying 6 of 1, half dozen situations where you're not sure what the best thing is, I feel a lot more comfortable talking to the person that I was told to talk to by the patient. Even if, again, for all of you, you were picking who the state says to go to, I would feel more comfortable if you told me to go to them, not the lawyers in the legislature. Okay? It helps. There's credibility there. Empowerment, permission, I've mentioned that. That adds to it too, right? Okay? You're telling the person you want them to do this. Don't feel funny about it. We've gone through some of the other reasons. The chutzpah thing, I'm glad that came up because I think that's crucial. Unfortunately, I mean, I work with physicians all the time. I think they still are kind of behind the curve on being comfortable listening to other views from people who aren't medical about what's best for patients. I think that's unfortunate. And I get the sense that they do better when at least they know the patient told them this is the person to talk to. Okay? Therefore, everybody should have a healthcare proxy. You should all run out and get one. Got it? Okay. Now, given our time, let's go a little further. Let's consider living wills, or in any formal sense, the idea of saying what you do or don't want if certain things happen. I already showed you the form. Usually the typical verbiage is talking about extraordinary care, excessive burdens over benefits, heroic. But usually you get boxes or something to check. If I'm PVS, I don't want anything. If I'm terminal, I don't want anything else. PVS, I'm just going to let go. Anybody want to stick around if they're diagnosed persistent vegetative state? Okay. There's a lecture that we could have given instead about whether we really want to give people the opportunity to indicate they want to stick around like that. Okay. But let's not go there. All right. Let's talk about terminal illness. You all know what a bell-shaped curve is. Terminal illness usually, and this is kind of out of hospice, the doc had to say that you had 6 months or less to live and then you're terminal, something like that. Okay, well, let's go to Harrison's medical text and look at pancreatic CA, and here's the bell-shaped curve, and this is 6 months, right? Pancreatic CA, mortality is 6 months from point of diagnosis, okay? What's the bell-shaped curve tell us? Well, those of us that are familiar with the illness, some people get diagnosed and it eats them up in a week or a month or something like that. Very profoundly aggressive disease, okay? On the other hand, for example, the former chancellor of the State University System of New York is alive 4 years down the line, and he worked for another 1.5 years beyond point of diagnosis, okay? So it's a terminal illness. And if these are obliged and staff are obliged to honor prior statements by the patient, if you come in with pancreatic CA, you don't get to see what these opportunities are. Maybe you got something acute that we can bring you back if we're aggressive, right? Got it? So those of you that, can you see why I might tend to suggest those of you that have done living wills, if you've checked the terminally illness box, probably ought to rip them up. Instead, name a proxy, talk to them about what you want, okay? You can certainly let them know if I have one of these bad cancers that could eat me up, and it turns out it is eating me up, then don't put me through that.
Usually, though, these are based on not only terminal illness, but they have to be coupled with incapacitated, which you're not awakening from. So it's one thing to have a terminal illness because we're all terminal. Whether we've got a 1 day or 90 years.
Hopefully both of our bell-shaped curves are not this one.
Right. But what I'm saying is that the real question is, if you're unable to go ahead and have a sentient life and you are terminally ill, then you're arguing more along the path of being irreversibly comatose or persistently vegetative. So if you have, let's say, metastatic pancreatic cancer and sepsis, and you are not sentient, you're not able to go ahead and interact with your environment. Mm-hmm. So that most living wills will say that you're terminally ill and incapacitated. It's usually not just terminal ill.
Okay. David is making the point basically that it gets more complex, and a lot of times what you're also seeing is somebody that is wasted, they are metastatic, et cetera, et cetera. I'm presuming to simply point out, however, that if you simply take pancreatic CA by itself and somebody comes in crashing and burning for no reason that's apparent to us yet, they are not available for comment, they are absolutely to be considered terminal. And I think if it went to most courts at least, to aggressively treat them would be considered a battery and against their wishes, all right? And that could just as well include my chancellor out here or all these people, even that say it's just 6 more months. You can do a lot of that end-stage stuff and saying goodbye and running off to Zanzibar and spending your disreputable children's inheritance, whatever you want to do, right? So rip them up. The other thing that I've seen in a few living wills is somebody saying, if I am out of it, which kind of gets to David's point, if I am out of it, incapable of decision making, and probably will remain so, then that would be another situation where I would not want to be treated aggressively. Okay? And again, we could talk about that. There are people who are incompetent but still can lead lives where they enjoy seeing their grandkids and all the rest. So that's not an easy issue either. The other thing that you can get on living wills, because they already have a comment section, would be you might say, I don't want any breathing machines, surgery, artificial feeding and hydration. Okay, you can say stuff like that. Now, and you might want to. Anybody here want to just across the board say, I never want to be on a ventilator? Anybody? Okay, we got one lady in the back. Another one? Okay.
I think it's going to say it's no breathing machines if quick criteria down there that if your quality of life is going to be zero or
zero? Quality of life is zero? Is that something clinically we can check out? It sounds a little bit like the old, if I become a burden, I don't want anything extraordinary, but okay. Okay. The problem with this sort of stuff, of course, is that sometimes they're inflexible. The person, say the moderate COPD or the camel man comes in, they got emphysema and they got bilateral bronchopneumonia. They're going to need a vent to survive, okay? But that may very well be an acute, reversible infiltrate that we need about 7 to 10 days on the vent for the antibiotics to work, and we'll get them home, for another year or 2 or 3, right? I mean, if you sit as I do daily in morning report in medicine, you see these guys coming back in, right? I mean, these are real lives. But anyway, here's the problems. If you do any of this stuff, it's binding on caregivers and surrogates if clear and specific to the issue at hand. Second, there's a whole spectrum. These documents you do at one point in time, in front of, say, your lawyer or whatever. But there's a spectrum that people are in. Healthy and independent, to you have a chronic illness or a functional decline. There's actually a nice, it has little circles that had arrows going in all sorts of directions, but I couldn't reproduce it, so I just have it here. Then you go to advanced chronic illness, then to multiple comorbidities and frailty, and then death with dignity. What you'd say at one point in that thing, you might say something somewhere else. Yes? Your views might change. Let me give you a quote from the Spanish. It's about bullfighting. It's the idea of saying things about situations you are not yet in. And the quote goes as follows. I wish I remember the Spanish. It's beautiful. Think of the bull ring. As one moves from the stands to the arena, the aspect of the bull changes. Right? Okay? Now, to do this garden variety, we certainly had any number of people that, while healthy and independent, would say, never want to be on a ventilator, oh my God, what happened to grandma, et cetera, et cetera. But when they get to the point that you get the tube or you're going in the ground, they have a marked tendency to say something different. Okay? Now, a good clinical approach there would involve, I think, making the point that there's more than one treatment for acute respiratory distress. The other one is morphine and comfort, right? So it isn't just it's the vent or whatever. But that comes up. The bull. The trick with something like that quote about the bull ring is how do we, and this is where it gets subtle, I think, how do we accept that sort of insight, which I would commend to you, but not just give up on the idea of advanced statements at all? Okay? I would certainly commend to you there needs to be a balance there. I've certainly had the situation where patients come in acutely short of breath, emphysema and all the rest, and maybe over Thanksgiving dinner or maybe in some document they said to the wife, I don't want a ventilator, but it's an acute respiratory infiltrate probably. 50-50 chance we'll get them off the vent. 50% chance they'll get stuck. In those circumstances, just about routinely, and you'll have a spouse there that's worried, I want to honor what my husband said, but I don't want him dead either, needlessly. And the way I generally go with that is I'll just say, well, did they talk to him about acute reversible infiltrates? Well, then, in my experience, what I'm guessing is he said no because he was thinking, you get a vent, you don't come off, and all the rest. That isn't true. Okay, you have the authority to stop it when it doesn't work. Let's do a trial intervention. Let's see if it could work. Okay? Okay, moving right along here. Taking stock, some caveats. First, every remotely competent patient should designate a healthcare agent. Second, tear up living wills, values, histories. Grids are something I didn't mention, but it's a grid where you have a number of end-stage clinical situations described up here. Then you have a bunch of clinical you got intubation, surgery, dialysis, feeding and hydration, blah, blah, blah. And you get to check what you do or don't want. Okay, it's a competitor to what David's got in mind. Yeah, I don't know if anybody's adopted it. It was an interesting intellectual proposition, but tear them up too. Let's see, second number 2, healthcare agent and the family should be involved while a patient of capacity is in discussions. We do this poorly, and even my European or Middle Eastern residents do this poorly. It's almost like when the patient crashes and burns, you're going to have to talk to somebody else. While the patient's with it, why don't you have them in discussions with the patient so they might hear something, see what's going on. You're not talking to a stranger at 3 o'clock at night when the patient starts to crump. But they don't do it, okay? Talk more, write less. I'm about at the point where I don't think you ought to write anything, okay? I think you should rely on the patient. Part of that is I've got too many of my clinical colleagues that think they can interpret these documents too and will argue with the proxies about what they mean. If it's not written, then bottom line, the healthcare, as it says in New York State, to us, we are to consider the proxy as if the patient was speaking themselves, okay? So we can give them 2 cents worth about what patients seem to think about this, but in the end, we should approach the proxy and say, okay, we've had our discussion, you've heard it all, we've kicked it around, what do you think the patient would say? Period. So I want to get rid of the documents. However, it occurred to me in all this to make a gesture to David and say, the informal use of a values history. Remember all those funny sort of poetic questions? That would be one nice way to sit down with a patient and the surrogate and say, go through this, ask them the questions. It might give you a little help. Don't let them write out their answers and sign it, though. Okay. Trial interventions, like I was talking, if you're not sure. We used to have a lot of the residents back earlier, everybody was real squirrely about stopping things that they started. Okay? And I've gotten absolutely brutish about that. What I'll tell people, so occasionally I do things with the pulmonary fellows, and I'll get one of them who's real uncomfortable about pulling plugs, stopping vents, and all the rest, and I'll just tell them, well, either get over it or get out of pulmonary medicine, okay? Because the options that your patients are entitled to, you're not going to be able to present them. In a more garden variety way, again, our emphysemic patient comes in with pneumonia in both lungs, okay? What's the best way to approach that patient? I don't think it's, well, you might get stuck on this, so maybe you don't want this, and let's see what we can do. I think it's to talk about trial interventions. Let's treat you from knowledge, not ignorance. Got it? The why is more important than the what. Goals of care, not just specific treatments. I think there's a tendency on our part to ask the questions that we need answered. That is, we're going to have to code them, we're going to have to do surgery, do we put them on the plug, and all the rest. Those aren't the real crucial questions. The real ones are goals of care. Okay, and I think some of that is gotten into by the values history. We have to go from advanced directives to DNR and the rest. For what it's worth, I'll just show you this real quick. This is what, aside from DNR orders, do we resuscitate or not? We actually have this list at my VA. This was put together by our ICU nurses, because interestingly, the residents would come up with DNRs, but they wouldn't have anything else. And DNR in New York State, and I think this is correct, only formally, specifically tells you, do you code a patient who goes into arrest? Is that kind of the way it's played here? It doesn't tell you how to manage the patient short of arrest. Okay, well, there's all this stuff possible. We can still tube them if they become acutely short of breath, surgerize them, dialyze them, all the rest.
There's a blanket way in which this would take place, is if you said comfort care only.
Yeah,
palliative care treatment only, and all of these would be excluded.
Yes, there's a way to do this, and there's a form called MOLST that some of you may have run into. There's various ways. These are orders. It's the difference between advanced directives. This is what I would tend to want and all the rest. These become orders that doctors write, okay, and it's really the gold standard. All right? But you have to get to that point. This is why we've got out-of-hospital DNRs sitting on people's refrigerators, right? Those are actually orders. They have to be honored even by emergency personnel. But what to encourage, recommend, and when? Actually, we've got 3 minutes here. My punchline, my take-home for you would be proxies for everybody. The rest of it, a lot of discussion if you can have it. Depends on how close to being on the launching pad you are. The patient that has metastatic lung cancer, hopefully somebody's going to talk to them about whether we should really put a tube down and ventilate you for the last part of your life, and suggest to them that perhaps in my experience, the time you will get beyond that point will not be good time for you or your family, and I think you should seriously consider telling us not to do it. Okay? Now that's a discussion when you're in the bull ring, though, I think. And I really get leery about asking people when they're healthy and independent a lot of these questions. Okay? I think those of you that are going out into practice, if you're, say, going to be a general practitioner in the community, I would say, again, get a proxy from everybody else, from every patient that you take on. Okay? Every one of them. You want to ask them that question. And you won't make them nervous, because they might say, well, why do you ask me that? You can just say, I ask everybody that I take on as a patient that question. Okay, but you don't ask them about what they think of persistent vegetative states, because they might tell you where there's life, there's hope, and then you've got to treat them, and you really don't want to. And it's a horrible way to spend the gross national product, et cetera, right? Again, like I said, that's another discussion. Comments, questions? You know where I'm coming from. Final thoughts? David, would you like to say anything for the opposition, if there is an opposition? Do we really differ here, then, or what?
I think it is very helpful. You leave it open.
Well, I want our web stream folks to hear this.
It's very, very helpful to begin the discussion with who your proxy is. The reason that I'll then proceed into asking about living wills is to make sure that there's documentation, so if there's any ambiguity or if the proxy is unable to fulfill their responsibility and they have to go to an alternate, something is documented to go ahead and help either that person or the alternative proxy. The other question, too, is if there's any possibility later that there's either difficulties with the proxy understanding or fathoming what the patient would want done, or a conflict of interest which might later emerge where you know the patient would want one thing but the proxy is saying something else. If it's written down in the proxies in the patient's hand, you now know and can tell the proxy, this is what we're supposed to be doing. Why are you saying to go in this other direction? And so that it then can encourage another conversation with that proxy about if there's been a subsequent change of heart by the patient that had been documented or just witnessed by another person, that there has been a change of what sort of things they want done in terms of end-of-life care. So my own particular bent is to have a durable power of attorney for health care followed by a living will, and then to have, indeed, a discourse, a discussion using the values history. It's intended to be a stepping stone to explore all the different philosophical, religious, and other values that are related to healthcare for future healthcare preferences.
Okay, I think I see where we part company. Using the values history for the discussion, I certainly think is an excellent idea. It's a way to do it. You're welcome. I wouldn't do the living will thing. Maybe one way to put it would be the living will thing is for folks that are healthier and independent or whatever, somewhere early in the spectrum. Okay, and I've become increasingly skeptical of any of those statements, at least if they're formal, binding, and we have to honor them. The folks later that want to say, I don't want this, like I don't want to be ventilated when I'm cachectic from lung cancer that's metastatic, et cetera, we don't need a living will for that. We'll write an order. We'll put it in the chart. We'll say no intubation for this patient, okay, because it's been sorted out. So the place where you would use the living will is back where I'm worried you're in the stands, and I'm not sure I want to ask them those questions. I'd rather get them in the living will verbally, and in the end we can go through all that. They said this. Well, what do you think they would probably say? Maybe that's where we divide.
Yeah, my difference also is based on empirical studies that we conducted back in Michigan, which showed that when you're dealing with people who are in their 20s and 30s, about 2 or 3% of people sign them. When you talk to their parents, this is a 3-generational study, then you're getting into like 10 to 20%. And then we get to their grandparents, they're upwards of 30 to 50%. But when we did a study looking at just nursing home patients, 81% of them had signed a living will. They knew that the sword of Damocles had it was slipping on the thread. And they wanted to make sure that there was some documentation saying, I don't want these things done. And you were talking about a state which did not have a living will law. They were using generic living wills. So I think that I think people feel more settled when they have these things, especially if it's coupled with a proxy, because then they say, I have a proxy, but not only that, I've now told the proxy in some formalized way what I don't want done, so that they'll carry it out rather than act on their own impulses. Because the worst problem that we have as ethics consultants is a family who responds to a question of what do you want to do rather than what would the patient want done. And sometimes we'll even say, what would the patient want done? They'll respond in their mind to what do you want to do? And you want to make sure that we're getting what the patient would have wanted done. And the only reason I like this belt and suspenders approach is because there is this validation, there's a check and balance to what otherwise could be a blank check to a person, as opposed to what the fear was in Michigan in terms of never passing a living will statute,
Yeah.
which was that there was a blank check to a piece of paper. And that's what they were concerned about.
Okay. I think you have it in front of you. Good enough. Thank you for your attention.
Thank you.